Some US stations of rectum. So how do we see the US stations? So this was slide prepared by long back, but this is what I want to say, that this is anal canal, this is lower rectum, this is middle rectum, and that is upper rectum. So when you go towards upper rectum, what is important is that you start seeing this peritoneal reflection just above the seminal vesicle. And this peritoneal reflection, as well as you see this the fat around the rectum. So in this is the stations in male. What about female? The difference in female is that the peritoneum comes much lower down and much lower down in the pouch of Douglas, and this is comes in between the vagina and the rectum. So the peritoneum reflection in the male is much higher compared to females. And this is the lower rectum, middle rectum, and upper rectum. So the similarities are, you can see the vessels here, but so this is example of lower rectum where you can see the prostate in front of this. And this is when you see the pubic symphysis, you see the urinary bladder pubic symphysis, and when you pull it back, you will see number one the urethra, and you will see the vagina as a transverse slit. So this is the layers of rectum, and what you can see is today interesting thing that you can see this is the hyper, hypo, hyper, hypo, hyper. Why the layers become hypoechoic? 1, 2, 3, 4. Because it is the muscle fibers, and when you see the muscle fibers, the sound goes fast through the muscle fiber. Wherever sound is reflected, this layer, this particular layer is hyperechoic because it contains a lot of fat in submucosa, and this is the layer outside. So 3 layers of hyper, 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 each with the reason, and 2 layers of hypoechoic lesion, each again with the reason why they are hypoechoic. So first and last layer reflects refraction, and the third hyperechoic layer, this shows the fat containing the. Some people do not know, but probably Dr. Bhatia will be demonstrating that when you are seeing the vessels in the rectum, you can go all the way up to the iliac fossa, and there is where you start seeing the division of aorta and the IVC. So the question is, which one divides first? So when you go from above, the aorta divides first, and then the inferior vena cava divides into 2 branches, and the right and left common iliac branches. So you can go right up, higher up into the rectum and see start. What is interesting in this image is that where the division of aorta is seen near the right iliac artery, there was a lymph node disclosed to the division of aorta, and this indicates inoperability in a case of aortic dissection. So the question is, how would you like to have a linear or a radial endoscopic ultrasound scope? So the radial endoscopic ultrasound scope is there. The thing is, today I don't use at all a radial endoscopic ultrasound. Even for rectum, I use only linear endoscopic ultrasound because I am comfortable and I like good quality, high zoom quality of images, and I believe that the same amount of crystals which are fitted in a radial ultrasound are fitted in a linear ultrasound, and they give very good quality of images. He's ready? Okay, 5 more minutes. I have 5 more minutes. Okay. So you can see all the structures when you use different kind of rectal probes, and this is urinary bladder, uterus, ovary, this is uterus, and then you can start following the urethra also within them. And then you can start following the vessels, you can follow the internal iliac vessels internally, and this knowledge is important if you want to see the circulation in the rectum, because this is the rectal muscle, and the first layer is internal anal sphincter, then comes the external anal sphincter. The important thing is the people fail to realize that this muscle, this is the longitudinal muscle which is part of the muscularis mucosa of rectum, continues down into the perirectal area as and where it divides like a finger. And when it divides like a finger, it gives on endoscopic ultrasound an appearance where fibers are alternating between hyper and hypoechoic areas. So these alternating hyper and hypoechoic areas are responsible for giving a special appearance on endoscopic ultrasound. On the other hand, there is an important venous circulation, and people will see the superior rectal vein is a continuation of inferior mesenteric vein, and it divides into two veins when it comes lower down, and this is the two branches which enter the lateral wall of rectum, and they continue with the rectal vessels as an astringent and extrinsic venous plexus. So these plexuses are seen. So you can see these plexuses, and the important thing is when the rectal varices are formed or the hemorrhoids are formed, they are formed in different zones. So this is a zone of intrinsic rectal venous plexus in anal canal, and this is the zone of external hemorrhoids. However, as you go up, this is the zone of internal hemorrhoids, and higher up is the zone of rectal varices. So the plexuses are responsible for formation of different kind of varices, whether they are external hemorrhoid, internal hemorrhoids, or the rectal varices. The important thing I would say, how long could be the rectal varices? They almost should not, if this is a pure rectal varice that has been formed because of the downflow of blood in the superior rectal vein, it should extend only below the bifurcation or the entry of superior rectal vein into the rectal wall, and this is where it occurs. It should happen only from 3 to 10 centimeter. So the rectal varices theoretically extend only from 3 to 10 centimeter. So then these rectal varices, you can see there is an inflow area and there is a downflow area. There is an inflow area and a downflow area, and you can see once you move your probe down, you can see them. So how do you see the rectal varices? These are a couple of cases we have seen and demonstrated: the rectal hemangioma, rectal wall abnormal vessels, and the rectal varices, and the individual venous plexuses. How do you decide that this is a venous plexus or a normal submucosal rectal varix? Is by the, so this is one part is lower. Rahul, I want one more interesting presentation to show, and that is if we can show you how to do reporting. We have shown you a couple of interesting things. How do you decide a tumor and all that? But this is a simple image, how do you report, how do you channelize, report, yes. So this is an important we see, reporting software, right? That one now. Okay, yeah, this is the one. So this is the reporting. How do you report? Because whatever types of stone we have seen, how do you report this stone? So we are trying to tell you that in these are the 5 parts of the pancreatic duct, and sometimes the pancreatic duct stones can be restricted only to this part, or to this part, or to this part, or to this part. So then you have to see exactly which part is showing the stone, and if they are restricted only to the, because this is the place where we are showing this is a stent going, and this is a stent, this is a stone which is here, and then this is the stone mainly in the common bile duct or in the pancreatic duct. So you have to identify which part, which place the stone is, and this part you can see these are the stones. They are not exactly in the bile one of the stone in the bile duct. These stones are like this. They are in the uncinate process duct only, restricted only to uncinate process stone. So this is another case where we are showing that there is a pseudocyst. Now the thing is, we want to show that we will be discussing tomorrow how to show that there is a duct disruption and all this, and where what happens we can show with the duct disruption. We will be showing tomorrow. So the second part I would like to show is that this is the figure, and this figure is the thing where we have this place and some. I will like to just escape and show you that this is the thing. We can make it bigger. We can make it bigger, and this is the tumor We want to show that this is the tumor is here, 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 and where is exactly is the tumor. We want to show where exactly the tumor is and how big is the tumor. So this tumor we should preferably try and show and relationship with portal vein. Like I can say today, the case that was done, there was mesenteric vein thrombosis, the one which ultimately proved to be a case of benign disease was somewhere a tumor here in the pancreatic head and body of pancreas, which was extending. It was extending into the portal vein, it was extending into the superior mesenteric vein, but what is on which side, this side, this side, I can leave it here. So, or whether I will copy it. So, you are ready?